Hello, everyone. Welcome to another session of the Connecting Minds to Progress AI in Medicine seminar series, hosted jointly by the Minds Lab, the My Lab, the Hot Lab, MRI Uganda, and the NAMI. Today, we are honored to be joined by Tufik Musa, who is a master's degree scholar at the University of Pennsylvania in Philadelphia, United States. He will be taking us through automated medical image segmentation and its implication towards trustworthy clinical tools. Taufik Musa is a biomedical researcher and engineer with interest in artificial intelligence application in healthcare. His recent work spans brain tumor segmentation, uncertainty estimation in medical imaging, and automated pathological complete response assessment in breast tumor treatment. He is particularly interested in developing trustworthy AI tools that address challenges in both low and resource-constrained settings. Today, Taufik Musa will be talking on his work that has spanned both the length and breadth of both segmentation and also breast ultrasound segmentation. Ladies and gentlemen, let's welcome Taufik as he take us to discuss. Over to you, Taufik.
Thank you very much, Maru, for the introduction. Hello, everyone. I hope you can all hear me.
Yes, you are audible.
Okay. So the title for my talk today is on automated medical image segmentation and its implications. And it's all geared towards the trustworthy clinical applications of such tools. So the talk outline, it's going to cover three main bodies of work, somewhat four, depends on how you count. The first one is on brain tumor segmentation, followed by breast ultrasound segmentation, and then also segmentation of dynamic contrast enhanced MRI and how it can be used for downstream tasks like pathological complete response assessment. So starting with a quick background, often when we hear about medical imaging, it's usually referring to biomedical imaging. And the main aim is to visualize the internal anatomical and physiological processes that are happening in the body, and sometimes even up to the molecular level with medical imaging procedures like PET, SPECT, and MRI. And the main aim of performing medical imaging is to diagnose and monitor disease progression. But most often when we perform medical images, the medical imaging procedures, like here we have the whole body MRI on the left, it's a whole lot of data that is difficult to manually analyze. So this is where medical image computing comes into play. And often when we talk about medical image computing is the application of computational methods to the analysis and sometimes acquisition of medical images. And currently, with automated medical image computing, it's often deep learning based. And that's mainly due to the rise in how deep learning models have shown to be very proficient in handling medical images. Okay. So when it comes to medical image computing and deep learning, there are some tasks that we apply deep learning to. And one of the most common ones is classification. So here, for example, given a brain MRI, can we classify the type of stroke that's present, whether it's an infarct, a hemorrhage, or just maybe a tumor? And also, there are other tasks such as registration, whereby you might have different modalities from the same patients that you'd want to register over each other. Deep learning has also been shown to be very capable of doing that. And finally, the main topic of today, segmentation, where when you give a deep learning model an input, it's able to pinpoint and then classify the pixels around an area of interest and segment it. So to the first part of the talk, which is on brain tumor segmentation. So brain tumor segmentation is typically the delineation of tumor-ridden regions of the brain to aid in treatment planning and also monitoring. And normally when it comes to segmenting brain tumors, it can be a very tedious process when it's done manually. Even though we see it here to be very clear and obvious in the images that we have as examples on the left, it may not always be so for a radiologist that has maybe tens of patients to look at every day. So it's important that they have automatic methods that can help them, especially in the resource limited settings where they might not have enough helping hands. So this is where the brain tumor segmentation challenge comes into play. So with the brain tumor segmentation challenge, what you'd have is multi-parametric, multi-label images that you'd have to segment for different tumor regions. And the multiple parametric images are of different MRI sequences, including the T1 MRI, the T1 contrast enhanced, T2 weighted, and then the T2 flare. And these MRIs come with segmentation labels of multiple different regions of the tumor. So as I mentioned earlier, it may not just be as obvious as, okay, there's a tumor here, so let me just segment it. There are very specific regions around the tumor that you need to segment for it to be clinically relevant. In this case, we have the enhancing tumor, which if you look closely at the images on the right, it's what is in red. Sorry, what is in blue rather. And then the tumor core, which is in red, and then the whole tumor, which is in green. So in the context of brain tumor segmentation and being specific to Africa, there are some challenges that we face when we want to perform some of these procedures in an automated manner. Most often, deep learning methods require a lot of data. And here's a case whereby we have limited amounts of data to use for training our deep learning models. The clear example that we have is when you look at the BRATS Africa challenge as compared to the BRATS Glee challenge, where we still have only about 60 viable cases to train with, compared to over 1,200 cases in the BRATS Glee, which is data coming from all over the world. And also another issue is with heterogeneous scanners and imaging quality. So normally you'd go to one hospital and then you'd get maybe one type of MRI scan, and then another hospital is not able to do that type of MRI scan. And even when they are all able to do it, their imaging quality can vary, which can affect how the model performs. And also there's an underreporting and a lack of centralized tumor boards, which makes it difficult to be able to track some of these tumor cases and also be able to get good images for tasks like these. So when it comes to the work that we did on brain tumor segmentation for the BRATS challenge, our main contributions include we evaluated some of the most popular segmentation models for biomedical image segmentation, including the residual encoder units, MEDNext, SwingNet R, and also SegMamba. And then we also looked at them specifically for their data efficiency capability, right? So for example, some models do very well with a lot of data, but we understand that within our situation, we can't really be looking at such models. So we have to look at data efficient models that can perform even under less data conditions. And another contribution that we did, which we are somewhat very proud of, is we introduced something called segmentation-aware augmentation and ensembling. With the segmentation-aware augmentation, we'll see more on that very soon. What we did was to introduce augmentations that are very specific to the segmentation task, and we saw that it led to some noticeable improvements in some types of metrics that we use to measure performance. Okay. So the first thing I want to talk about on the technical side of things here is the segmentation-aware augmentation. So the aim here is to introduce some rigorous elastic transformation augmentations in the tumor region. So normally when you apply augmentations in deep learning training, what happens is that the augmentations are applied everywhere within the image. So now we ask ourselves, is it really necessary to do that for medical images? Because sometimes medical images, they have specific structure to them that would always remain the same. So if you introduce some elastic transformations that distorts the image too much, what will end up happening is that the image is no longer anatomically plausible. So in this case, you would say that this image doesn't hold the same quality as an actual real life image. So you take these two images that we have side by side, for example. One of the regions that you see has the most augmentations is within the tumor core. So here you see in red this tumor core compared to this tumor core. And also, even if you look closely to regions around the enhancing tumor and then the whole tumor, you realize that the augmentation is very specific to the regions of interest, which is around the tumor. So here in this case, if I apply these augmentations twice, and I have maybe 60 image samples, I would end up with 120 unique image samples that the model can learn more from. So on to the modeling. After after getting the data down and done, the next thing is to look at the models. So one of the most popular models that's used to date is called the NN unit or the no new unit. And I'm saying this anecdotally, that is maybe the best open source biomedical image segmentation pipelines out there. Here, I specifically say pipeline, not model. It's based on my own reservations, but it's one of the best pipelines that you can use out there. And when it comes to medical imaging tasks in general, it's not just about the model, but it's about the entire pipeline that you'd apply. And another model that we use that we'd also be looking at is MedNext. So MedNext just came somewhat recently, maybe 2023, and it's seen a lot of good use cases for medical image segmentation. And it's probably the best open source medical image segmentation models out there. And it does so in a very efficient manner, such that it's about 10 times smaller than the NN unit, but it does comparable and even better in some situations. And it's also been able to introduce very strong image feature extraction architectures. For example, in the way that they design their mid-next up and down blocks. Okay. And another thing also would be the fact that the mid-next architecture tries to approximate the transformer attention. And I'm sure we've heard a lot about transformers and how they introduce this mechanism of attention. Attention is not intrinsic to these models that we are looking at because they're mostly convolution based. But mid-next is able to somewhat approximate attention with some of its design choices. For example, the fact that it uses something called the AppKern, whereby it can use large kernel sizes to be able to see much more larger portions of an image to perform the medical image segmentation. So another model that we worked with is called Swain Unit R, or also called the shifting window unit. So the shifting window unit is made up of a transformer-based encoder and a convolution-based decoder. And within the encoder, transformer-based encoder, is specifically something called a shifting window transformer. And here again, we saw convolutions trying to approximate transformers. But in this case, transformers are rather trying to approximate convolutions by performing some operations that seem like convolutions with the shifting window movement. And another thing that the strain unit R does here, the reason why we call it V2 is because it introduces intermediate convolution blocks between the transformers in each of these encoder layers that we see here. And the final model that we worked with is called SegMember. So SegMember is a state space based encoder model. So in the previous model, we saw that it was a transformer based model, but in this case, it's rather a state space based model, which is in this case called a Mamba module. And the best part about this, it works similarly to the transformer, but it's 4 times more efficient. So especially for situations where you might not have a whole lot of compute available, the state space model would come into play and perform comparable to the shifting window transformer unit and with 4 times efficiency in its computations. So the results, how did some of these models perform when we use them for segmentation on the BRATS Africa Challenge dataset, and let's look at it. So here, NN here means no new units. And when we applied it on its own, it performed somewhat okay, but we realized that the MedNext actually performed much better under somewhat similar conditions, which is the reason why I said MedNext is one of the best segmentation models out there. And again, the main method for evaluating segmentation is the dice, right? But then it's not necessarily the most important. Another very important metric is called Hausdorff distance, where it measures the boundary, how close your segmentation is to the boundary of the actual ground truth. And here again, we see that the MedNext, which is labeled with M, is also able to perform much, much better than sorry, not much, much better though, but then somewhat comparable to the NN unit. So yeah, the results that I showed you are as of 2024. So these results are from this year, 2025. And you realize that they are much, much better because we've been able to run more experiments and we're able to see that, okay, some of these models perform better than each other. So the S here denotes SegMember, M denotes MedNext, and R denotes the NN unit or residual encoder unit. So we realize that for our best performing model, which was the MedNext, it's outclasses all the other ones. And even when we try ensembling, we realize that it's ensembles that have mednex in there that also perform much, much better. So with ensembling, what we do is we take the results from each of these models individually and we combine them and we kind of vote on them using different methods. For example, we can use, in 2024, we use a method called staple ensembling. And in this year's version 2025, we just ensemble them using probabilities. And the difference from between last year and this year, of course, we had more time to experiment, and also the metrics for judging also somewhat changed for evaluation. This time we are using something called the normalized surface distance. It's also a boundary-based evaluation, unlike DICE, and very similar to Hausdorff. Okay, so for the next part of the talk, we'll be talking about a very recent paper on breast ultrasound segmentation and epistemic uncertainty estimation. So you can easily find the paper online, but after this talk, you can always ask for a link. I think the links will be part of the slides too. So breast tumors are usually masses that you find in the breasts due to abnormal cell growth. And we know how this can lead to either malignant or benign cancers, right? And the reason why you might want to segment breast tumors is to enable surgical planning and radiation therapy planning, as well as characterizing the lesion. For example, being able to tell whether the lesion is a benign lesion or a malignant lesion, because these things can be very important in how the tumor is treated. And another very important one that you don't really hear about is something called pathological complete response assessment. And we'll see more on that in the third paper, sorry. And with pathological complete response assessment, here you are trying to tell whether or not the treatment that the patient has received was sufficient, and then the cancer would not continue to proliferate. And the reason why we have trustworthiness in this case is because, specifically because we are performing uncertainty estimation or uncertainty awareness. Here we are able to tell how certain the model is in its outputs. Because even though some of these models perform quite well, they end up with some issues such that they might be wrong, and then you can't really tell whether or not, okay, is it confidently wrong, or it's unconfident and it's also wrong. We'll see what that means very soon. So with this work, the main dataset that we used is called the breast ultrasound images dataset, or the BUSI dataset. And it's a very, very popular dataset. But then the issue with this dataset is that it has some duplicates, which people don't account for when they use them for their various works. So this is where trustworthiness also comes into play, right? So you'd use something like this dataset to train your model, maybe your new state-of-the-art model, and you realize that you've gotten very high scores. But the issue here is that because the data set has duplicates, there will be data leakages between training and validation. What would happen is that your DICE scores or your evaluation scores would be inflated, and the scores will be somewhat unrealistic. So when you end up deploying this in the clinical setting, it doesn't reflect the performance that you saw when you were first training your model. So let's take a closer look at what this looks like, the duplicates. So within the data set, if you see an ultrasound image like this, what ends up happening is that that same ultrasound image would appear again, but it will have slightly different segmentation. So in the first instance, it has a segmentation in blue, and in the second instance, it has a segmentation in magenta or somewhat red here. So your model will see both of these within the training data set, and it's somewhat able to transfer knowledge from one of the segmentations to the other, although not perfectly overlapping, it's still transferring some amount of knowledge in this case. And you don't want that to happen. So when we train our model on the BUSI datasets, in order to validate its real-world performance, we decided to use an out-of-distribution test data to see how it performs for data that it has never seen before. And this is one issue with ultrasound images, and you'd see it all around in medical imaging in general. If you remember, I made mention of heterogeneous scans from the brain tumors, brain MRI scanning. It's also a very similar case for ultrasound. So you notice the ultrasound that we have here look somewhat brighter than the ultrasounds that we have here. And these can be as a result of the different types of scanners, maybe different breast densities, as well as maybe the operator's preference in how they set up their scanners. So you train one model in one hospital setting, but when you move it to another setting, it doesn't perform as well as you expect. So how then do we tackle this on the modeling side of things? Here again, we used NN units. We made mention of it earlier. We introduced some new things to NN units. Specifically, we added dropouts to NN units to enable us to be able to perform the uncertainty estimation that we mentioned earlier. We'll talk more on how that works. Okay. So with uncertainty estimation, what you're trying to do is to determine whether or not your model is very sure about what it's saying. And when the model is sure, is it right? Right. So for example, when you ask your model to segment a tumor, and then the model segments the tumor properly, the model should be very confident about the segmentation. But when the model is then not able to segment and it maybe does something that is somewhat wrong, the model should also be able to reflect that within its confidence too. So if the model is wrong, it should have low confidence. If the model is right, it should have high confidence. And when you achieve that, that is called you check whether you've achieved that using something called expected calibration error. And the way to model this uncertainty is in three main ways, which we explore in this paper. The first one is called Bayesian approximation or Monte Carlo, Bayesian approximation Monte Carlo dropout. So what happens is that at every forward pass of the network, some of the network parameters are dropped. So in one forward pass of data X, some parameters of the model are dropped, and only the active parameters are used to make prediction. But then in the next forward pass, another set are dropped again, and then say maybe 30%, and then the remaining 7% would then be used to make prediction, and all on the same data. So if you do this maybe 10 times, the hope is that all 10 predictions should look very similar to each other. But if you end up in a situation whereby the predictions are far from each other, it means that the model is showing a lot of entropy, and we'll see what that means soon. And another way of modeling uncertainty is something called deep ensembling. So in deep ensembling, you'd create maybe different folds of the same model and then train those folds on different types of that same data set. There are different ways of ensembling, but then this is how we did our deep ensembling, using different folds of the data. So within this deep ensemble, say if you have 5 folds of the same model, anytime you give any of those 5 models an instance of a data, you expect that all those 5 models should output the same data, the same output. But then that's not often the case. And you'd see some differences between each of the models' outputs. And when you measure some of these differences, you can then see the entropy in the model's outputs to measure uncertainty. Okay. So with that out of the way, so how then do we use the problematic data in training our model? So we made mention that there are duplicates in there. But in order to remove the duplicates, we inspected the data closely and realized that the duplicates form in groups. And we just labeled them group A, which is A1, sorry, A1 and A2. In group A1, when we removed the first occurrence, we called that data set A1. So in the data set of about 700 images, when we remove the 200 duplicates from the first occurrence, we call that A1. And then when we remove the second occurrence, we call that A2. And then finally, we let a radiologist look at the data set closely, and then the radiologist was then able to determine which groups we should keep or remove, which formed A3. So looking at the data again, just to get a clearer understanding, when you look at this ultrasound image, and within the data set, it would occur twice. In the first occurrence of that image, you realize that the segmentation is somewhat close around the boundaries, which is somewhat correct. And in the second instance of it, you realize that the segmentation is just all around, like it's done somewhat haphazardly, which is relatively less correct compared to the first one, right? So when we dropped the first and second occurrences, we just did that just because of how the groupings were. But then in the third BUSI A3, we didn't just drop them haphazardly. We let a trained radiologist look at the data set closely and determine which one should be dropped. So in this case here, as an example, the radiologist picked the segmentation that was much more closely aligned to the tumor than the one that was done haphazardly. Okay, so how then did this perform when we applied them on our model? Let's just mainly look at the top and then the bottom, right? So when we use the full data set with all of the duplicates in there, we realized that our dice score was relatively high at around 0.75 dice. But then when we removed the duplicates and we trained it this time without any data leakage, the dice score went down, which is to be expected because this time we don't have any data leakage that would inflate the scores. And then also for A2, the same thing also happened. There's a drop, and for A3, it's slightly higher than A1 and A2. And this one we attributed to the fact that A3 was selected by a trained radiologist. So the segmentations are actually anatomically plausible. And we performed some statistical tests to ensure that the A3 results are actually significant compared to the rest of them. So after training A1, A2, A1, A2, A3 on the model, we took only A3 as our best performing model, and we applied it to the second data set that I showed you earlier. So what that means is that we train a model on this data set, and it performs well. For example, maybe it gets a score of 0.72, and then we then take that same model and apply it to this other data set. So a very different looking data set. The expectation here is that the performance of the model should drop, but then we hope it will not drop significantly. But what we witnessed in this case was quite different because the drop was somewhat significant. Here you see ours, A3 out of distribution. The dice fell in the original scores from 0.72 now all the way to 0.48. And here we attribute it to the fact that the data sets from training and testing are very, very different from each other. And it's a real world scenario whereby different hospitals would have different scanning parameters, which would lead to very different images. So these are things that we have to take into account when we make and deploy these models out there. So let's also look at how the models perform qualitatively. How do they actually perform the segmentation qualitatively? So let's look at an example here, which is a very easy case, somewhat. So you can clearly tell that here's a ground truth. But then when we give this ground truth to our models, this is a model that was trained on this same data set. This model is able to perform well. And the same way when we give it to a model that was trained on the out of distribution data, it's also able to perform somewhat well. And then when you look at these entropy maps, remember I made mention of entropy maps earlier. So what happens within the entropy maps is that you would um you would perform a stochastic forward pass on the model several times, either with the Monte Carlo dropouts or the deep ensembles. And each of these times would create an entropy map. When you perform this a number of times, it will create an entropy map, which shows like regions of high certainty and regions of low certainty. So for the regions that are in bright yellow, those are regions of high certainty, and the regions that are of like darker blues are regions of lower certainties. And then another interesting case is this very one here. So the ground truth looks like this, but then when we asked both models that were trained in distribution and models that were trained out of distribution, they both were not able to determine that this tumor has a tail of sorts. But then when you then question this same model here on its uncertainty, you realize that within this uncertainty, it's able to show a tail, but it doesn't reflect that in the actual predictions. So in this case, we are able to show this to a radiologist that's trying to maybe perform this on a large scale. They can clearly see that, okay, it seems like my model is unsure about something. And the uncertainty here is important to the final decision that I would have to take at the end of the day, right? Because in its uncertainty, we can clearly see that there's a tail, but in its actual predictions, that there is no tail here. Okay, so another case that we can look at is this final case here, case number 8, which is a relatively difficult case. For the untrained eye, you would never be able to tell where the tumor is. And this is where the tumor is supposed to be present. And for the model that was trained on this same data set in distribution, it's able to tell that, okay, there's a tumor here. But for the model that we spoke about earlier, that was trained on the other data sets, it doesn't show any tumor at all. It's not able to even determine where a tumor is. It just tells you that there's no tumor at all. But then when you then question it up and with epistemic uncertainty, it's showing maybe regions of uncertainty somewhere up here, right? Which is still somewhat wrong, But here you're able to see that there's some uncertainty in its decision-making process, which can be important in the clinical setting for the doctor to be able to tell, okay, is this model certain or uncertain in its decision-making process? So what does this mean quantitatively? So for the uncertainty estimation methods that we applied, it was three main methods, including Monte Carlo dropouts and then the deep ensemble. And then we also finally did a combination of deep ensemble and Monte Carlo dropouts. So for every model, for every ensemble, you perform Monte Carlo dropout on it. And some of the important metrics here is the ECE and then the entropy. So the lower the ECE, the better. And here we see that the lowest ECE that we get is 0.30. And also there was no statistical significance between the deep ensemble and then the deep ensemble Monte Carlo dropouts. So it shows that deep ensemble here is a very strong, it's very strong at performing uncertainty estimation, maybe specifically for the use case that we applied to here. And also we looked at the uncertainty histogram. Another issue with the way that we performed uncertainty estimation here is that this method is just specific to tasks like classification. It's not specific to segmentation. So you realize that the correct versus wrong, the correct is somewhat like very high within these regions, but then very low at others. This is actually a log graph, so take that into account, right? And you can also see that in the pixel-wise accuracy, because the pixel-wise accuracies that we get here are relatively too high. Here you are getting pixel-wise accuracies of 0.96 and above. And what this is trying to tell you is that okay, wait, even if you compare this to the DICE score performance, we saw that the DICE score performance was around 0.4, 0.48 or so. But I'm comparing it to the pixel-wise accuracy, which is very high. It's somewhat unrealistic. So it shows us that the model is poorly calibrated, and at the same time too, the evaluation that we are using to tell for the epistemic uncertainty is not very honest, right? So it means that we can't realistically deploy this model in the clinical setting and expect it to be trustworthy. Okay. So with that out of the way, the next one we'll be talking about is using a large kernel mednext for breast tumor segmentation and a self-normalizing network for PCR classification. But then this time we are using the dynamic contrast enhanced MRIs. And again, breast cancers are a very major concern, health concern. And for regions where MRI is available, it's very much used in the process of assessing the cancer. And one of the assessments that occurs with breast cancer, especially during and after treatment, is something called pathological complete response assessment. And it's a process that's normally done invasively, meaning that it's either they perform surgery to extract the tumor, not necessarily to extract it, but then maybe just to take out parts of the tumor to tell whether or not there's something called pathological complete response. Here, this means that the tumor, the cancer is responding to treatment, right? And surgery and biopsy are very painful procedures, which some people don't necessarily need to be subject to. Assuming we are able to tell this pathological complete response only from the images. But this is one of the um, more important aspects of biomedical imaging and medical image computing coming together. So we are able to perform advanced computation and analysis to be able to determine some of these things that traditionally you will not be able to tell that this person is experiencing pathological complete response without having to perform biopsies, right? So here we are trying to eliminate the painful procedures that the patient has to go through to determine that. So the main contributions for this work is the first one is that we use a two-stage training approach with the large kernel mednext. You remember mednext I spoke about earlier? Yeah, so here we use its ability to approximate attention and train it in a two-stage training manner. And then we expand the kernel size from 3 by 3 by 3 to 5 by 5 by 5. What this simply means is that we are training it, first of all, to see smaller regions. And then the next time that we train it, we now train it to see much larger regions. So it's able to translate the information it learned from the smaller regions to the larger regions without maybe suffering from performance drops. So another thing that we did here was to ensemble different models of the same mednext that were optimized based on different loss functions. So normally when we train our segmentation models, we just train them on region-based losses like dice. But often it's not just dice that's important. There are some other very important metrics too, like maybe Hausdorff or the normalized surface distance that we spoke about earlier. So if you're able to optimize your model towards also performing well in terms of Hausdorff distance and normalized surface distance, you'd realize that it's more clinically relevant in its segmentations. Okay. And finally, we do radiomics based, so we do a radiomics based self-normalizing network for the pathological complete response classification. And the reason why we are using a self-normalizing network particularly is because this network has shown very strong performance in high-dimensional numerical data. And radiomics data is high-dimensional and often it's often high-dimensional and numerical in nature. We'll talk more about radiomics very soon. Okay, so onto the methods. So starting with the large kernel med next. So we give the large kernel med next an input of the dynamic contrast enhanced MRIs in multiple phases, and it's then able to perform segmentation. So here you notice that the segmentation that it's performing is like somewhat a difficult case. It's not like earlier with the ultrasounds that we can clearly tell that there was a tumor there. So in this case, like we have much smaller tumors, and then the model is able to pinpoint where the tumor is. Yeah, so again, it's the same design features from earlier on that are giving it an advantage in this case too, like the app kerneling, and also the strong feature extraction performance. Okay, so then other than the segmentation, another thing we did was the radiomics feature extraction. So radiomics here is there are features that are intrinsic within an image, specifically radiological images that we can use for downstream tasks. So these features are somewhat handcrafted. When I say handcrafted, it means that someone designed an algorithm for extracting these features. And then when you apply this algorithm to it, it's able to extract the features that we can use for downstream tasks. So the main features that we can talk about today are the shape features, and then first order GLDM, and so on and so forth. So when these features are extracted from an image, they can be very meaningful for downstream tasks like pathological complete response assessment. Here, for example, maybe the tumor is shaped in a very weird way. If the tumor is shaped in a very weird way, your deep learning model does not necessarily have a lot of information on the shape of the model. It doesn't necessarily know the shape of the model in a numerical manner. It just knows, sorry, the shape of the tumor in a numerical manner. It just knows that it needs to segment the tumor, right? So now if you then want to determine pathological complete response and you want to use the features of the tumor, the best thing to use is radiomics. So radiomics would then look at several features of the tumor, like its size, shape, intensities, and so on and so forth, and then extract these radiomic features, the shape, first order, GLDM, GLCM, and so on and so forth. Some of these features can be anywhere between, you can choose either one feature or up to 128 features. So even you can also create your own features that you can use for your own downstream tasks. Right. So we use these features as an input to the self-normalizing network. The self-normalizing network is not some very scary thing per se. It's just any multi-layer perceptron network which uses the scaled exponential linear unit activations. So instead of the everyday ReLU activations that we are familiar with, this time we rather use something called CeLU. And we also introduce alpha dropout, which is specific to the CeLU activations. So what this enables the network to do is that it normalizes itself intrinsically. So you don't need to add normalization layers, which can sometimes increase training times and reduce the speed at which your network converges. Okay. So yeah, this is how the architecture comes together. So given that you perform radiological imaging on a patient and you get their DC MRI and give it to the first network would here perform segmentation. And then based on the segmentation, we perform radiomic feature extraction. So you see here why segmentation would be important. Because without segmentation, we don't know what the tumor looks like in order to be able to extract the features from it. So when you then extract the features, you are then able to tell pathological complete response. And in so doing, if it's a very good model that has shown very good performance in both in distribution and out of distribution. You can see how this can be very important in the clinical setting, such that it can cut out the need for some of these painful biopsies and surgical procedures that can be sometimes even introduce more risks than necessary. Yeah, and also I'd like to mention this process is not maybe exclusive to the DC MRI. You could also perform it with ultrasound, but it might be a more difficult process to do that, given that ultrasound is often done in 2D. But if you perform 3D ultrasound imaging, even you can even use 2D too, but then it might be better to do it with 3D ultrasound. Okay. So experimental setup. How do we train our MED-NEXT? You remember earlier I made mention of the fact that we do a two-stage training approach, and then we also do an ensemble of different MED-NEXT that were optimized on different loss functions. So we first of all trained the MED-NEXT with the 3x3x3 kernel sizes, and then we picked the best fold from this, and we performed something called the upkerneling. So upkerneling here, we expand the kernel size of the MED-NEXT from 3x3x3 to 5x5x5. So here what happens is that it will have a larger receptive field. So it's now able to look at much larger portions of the image to perform the prediction. You might ask yourself, why not just use the larger kernel sizes from the very beginning? What happens when you do that is that the model will get saturated. It is now looking at like a very large area to make decisions, and it might not like converge properly. So here, when you use small kernel sizes and expand to larger kernel sizes, the model is able to remain more stable in its learning process. Right. So yeah, after getting the 5x5x5 model, we then also train that same model again, this time no longer using dice and cross entropy, not just dice and cross entropy, we also use something called the focal loss. And the focal loss is very important for cases whereby you might have very small, like a very bad balance of your ground truth versus, so your foreground versus background, or in the case of classification, positives versus negatives. You notice from the MRI scans that we've seen that the region that you need to segment is very small compared to the entire image. If you compare this to the brain tumor segmentation, you realize that the tumors can be somewhat large in the brain. So some of this imbalance is not really experienced. But for this particular case, you notice that there's a lot of imbalance in there. So when you then get these two models, one model that was trained exclusively and optimized on dice, another model that was optimized on dice and then focal loss, you ensemble them. And yeah, we saw that this was what gave us the best results. Right? But then we actually extended this. We also trained another model on Hausdorff distance, and that was what gave us the best results possible. So there was a baseline that was established by the people that released the data sets. And for their baseline, using a model of about 140 million parameters, these models can be very heavy to train. They got a die score of 0.65 and a normalized Hausdorff distance of 0.30. So in our first instance of training with the T/T/3, we only got 0.64, right? But then after we expanded it to 5x5 here in the first upkerneling, you would notice that there was a significant jump from 0.64 to now 0.66. But then you see that the normalized Hausdorff distance doesn't really change much. But then when we optimize the model now for being able to segment for smaller lesion regions with the focal dice, what the focal dice cross entropy here will do is to penalize the model more if the model tries to segment for the imbalanced regions, right? So here we see that the dice score increases marginally, but then the normalized Hausdorff distance reduces much more here by up to 0.06 from comparing from the first baseline. And I made mention earlier, it's not only dice that is important. Some of these metrics are also very important for clinical evaluation. So what this means is that your model is able to segment closer to the boundaries of the tumor, right? Because if the boundaries are inaccurate and then the doctor wants to use it for maybe something like radiation treatment or even maybe surgical removal, and your boundaries are wrong, you know what can happen is either they resect too little or they resect too much, right? And one of the important things that you should see from this is the parameter sizes. These parameter sizes are almost 5 times less than the original model's parameters, but then they're able to perform very comparatively. Okay. Yeah, so after performing the segmentation, The next thing is to then use the segmented tumor to determine pathological complete response assessment. And an interesting thing that we noticed was that when you're performing pathological complete response for some types of patients, you get very good results as compared to some other types of patients. So it shows that there's some kind of lack of fairness in how the model performs in some groups. So if you give this model to anyone between the age ranges of 41 to 60, you can get accuracies of anywhere between 62% all the way to 75%. But you notice that if you use maybe a patient of age maybe 70 plus, you see that the accuracy is very, very poor, right? And also when we checked for its accuracies for premenopausal versus postmenopausal patients, there was not really any significance in that. But then also it showed a lot of significance in the breast densities, right? So for people of the group A breast densities, it showed like very good accuracies within that group. So what this tells us is that although our model performs well in some groups, it might perform very badly in other groups. And another thing that we noticed was that for performing pathological complete response assessments, if the model gets a poor segmentation score, the pathological complete response assessment often also ends up being wrong, right? So here it tells us that it's important that you're able to perform the segmentation accurately. So it's not every time that you just perform segmentation for segmentation's sake. We can use them for tasks like these that can very much save people's time and pain, and even maybe for situations where they can perform some of these invasive procedures, you can easily tell that, okay, the cancer treatment is working, and or maybe it's not working, and then you might need to do something different. Okay, so thank you very much. Most of these papers are available on my Scholar, and the slides can also be made available. I'll add links to the paper. And yeah, any questions?
Thank you so much, Tofik. This is a really well prepared and delivered lecture. And even having been working in segmentation for a long while, there's still a lot of things I learned from this particular lecture. One key interesting question I would like to ask is, what is it to you and cats? There seems to be cats on every page of your slide. Are
Uh,
they contributing to the accuracy of your segmentation models?
Actually, yes,
Oh, do
they,
you
they
care
very
to
much
share
are.
some light on
Okay,
that?
I'm actually kidding, but then it's just the template that I chose to use.
Oh, okay, okay. All right,
Yeah.
that's nice to see. We have a couple of questions here. One of them is that are there any case sensitivity to imaging modality when you are performing segmentation? I think what this person is trying to ask is, when you are segmenting on CT or segmenting on MRI, does that influences the accuracy of your dice score?
Okay, so I think this will be dependent on what you're trying to segment. So in CT, for example, if you're trying to segment maybe objects that are calcified, maybe bone and stuff of that nature, you might have an easier time doing that with CT, as I'm sure you'd also agree. But then if you're working with stuff, maybe soft tissues, definitely MRI will be a much better alternative.
Yes, all right, that's one. Then another question we have here is that multi-segmentation, does it works more accurately than when you are doing a single segmentation? Like, you remember in Black Africa, we have sub-regions.
Mm-hmm.
Does that work more effectively compared to when you are segmenting only one
Okay.
structure?
Um, the, the the answer I'll give to this will be somewhat anecdotal, such that it's expected that the model would have less work to do when you're only segmenting one region as compared to multiple regions. So I'd imagine that there might be some marginal changes in that case. But then if you are trying to perform multi-level segmentation, I'm sure that will be important to the task that you are performing. So I believe the model should then be optimized to be able to do that.
I see, I see. So those are a couple of questions we have here. I would like to thank you once again and request if there are any other person who has one or two questions, to kindly notify us now. Otherwise, we would bring today's lecture to a close. It's really been engaging. It's really been interactive. Thank you so much for sharing from your wealth of experience with us this evening. And we hope that when next we invite you to give another talk, you honor the invitation.
Hopefully.
Thank you so much, Tufik. Have a great day. Thank you so much, participants. The recording to this lecture will be available on our YouTube page. We invite you to share it and watch other episodes. And we also invite you to join us the same time next month for another interesting topic on medical image quality, especially as it affects resource constraint settings across the two. Thank you so much once again for your time. Do have a lovely rest of your day. Bye.
Thank you. Bye.